So our topic for today is going to be a research update on the Bionic breast, oh my goodness, Bionic breast project from the Lindo Lab at the University of Chicago. A few housekeeping notes. Again, please remember to remain on mute when you're not speaking so that we cut down on background noise. I have to change this slide. It is not being live streamed to Facebook Live because that has not been working. We still have to troubleshoot that, but we are recording it as the recording notification would let you know, and we're going to upload it to our YouTube. If you have any questions during the presentation, please use the chat box to ask those questions. And if you would like to ask a question anonymously, you can find my name, which is Aleopoulos. It should say host next to it, so it should be clear who that is. You can DM or direct message me a question if you'd like it to be asked anonymously, and I will ask it on your behalf without revealing your name. So as mentioned, my name is Aleopoulos. I am an education outreach specialist in the Office of Community Engagement and Cancer Health Equity at the University of Chicago Medicine Comprehensive Cancer Center. So this is a picture of our team here, and this is part of our programming as trying to link the larger University of Chicago and beyond community with some of the great research that is being done at the University of Chicago. So as most of you know, Breast Cancer Awareness Month is October. This is part of our Breast Cancer Awareness Month webinar series. Again, I just want to run through some real basic slides about breast cancer before we switch gears and get the research update about the Bionic Breast Project. So breast cancer is the most common cancer among women in the U.S. About 1 in 8 women will develop breast cancer in her lifetime, and so it's about a 12% risk. And it is the second leading cause of cancer deaths among women, second after lung cancer. We talked a little bit about this last week, but cancer screening, breast cancer screening is the best way, of course, to catch breast cancer. Luckily, it is the most common cancer among women, but it's also one of the most screenable, right? Some cancers are really difficult to find, and luckily we do have good screening tools for breast cancer. So the recommendations are sometimes changing and they can be confusing, but basically we think all women should have a risk assessment that's talking to your doctor about your family history, about your health history, and have that risk assessment done by age 30. And with annual mammography or mammograms starting at age 40. And screening should continue past age 74. That's something, again, when you reach 74, 75, that's a conversation to have with your doctor. But the new recommendations are that there's really no upper age limit unless there are severe comorbidities with mammograms. For a woman who has an average risk, meaning there's no family history, there's no known genetic mutation, and no prior chest radiation, um, the guidelines are similar. They're a little different. The American Cancer Society suggests that women between 40 and 44 should start screening with a mammogram every year. The U.S. Preventative Task Force recommends that women start at age 40 and go every other year until age 75. So this is something, again, all women should start at age 40, talk to their doctor about whether to go every year or every other year. I think from age 40 at least until 54, 55, every year is the norm. And then it depends sort of on the person if they switch to every other year or keep them every year. Again, it's really something that you talk to your doctor about to figure out what screening plan is going to be best for you. The guidelines can be confusing, but the bottom line, start at age 40, can continue past 75 unless there are other comorbidity or life expectancy issues. Usually every year, again, every other year, maybe your doctor might recommend that, but typically every year is when mammograms are recommended. And then you can discuss with your doctor if you have other considerations to go every other year, and your doctor is the one that can help you calculate your personal risk. High risk patients, those are people who have a known BRCA mutation, so that's BRCA1 or BRCA2, or have a lifetime risk of breast cancer of about 20% or 25%, according to risk assessment tools. Again, that's something that you do with your doctor. If you have a first degree relative with a BRCA1 or a BRCA2 gene mutation, if you've had chest radiation before you were 30, or have any of these syndromes, Lee-Fraumeni, Cowden, Benai and Riley, or any first degree relatives that have one of these, those are going to be considered high risk patients, and they should get a breast MRI and a mammogram every year. So 6 months, you get a mammogram, 6 months later, you get your breast MRI. 6 months later, you get your mammogram. 6 months later, you get your MRI. So you're alternating every 6 months with those. Um, Self breast exam, this is not recommended to take the place of mammogram screening. You should be familiar with how your breasts feel and look just so that you can know your own body and notice any changes. If you notice any lumps or anything that feels weird, that's something to report to your doctor. Um, but it should not take the place of regular screening. This is sort of an overview of what we just talked about. And then we touched on this last week. In fact, last week's webinar was all about this for women with dense breast. So dense breast tissue makes it very hard to spot cancer, and mammograms sometimes miss cancer on a woman with dense breasts. So if you have dense breasts, and the only way to know is to get your mammogram report and see if you have dense breasts from that. If you do have dense breasts, you can ask your doctor to order a supplemental screening, either an ultrasound or an MRI, and that's going to be more sensitive and able to find cancers that may be missed on a mammogram. So that's my breast cancer screening spiel. Now we're going to throw it to our speakers for today, who are from the Lindau Lab. We have Tanya Mendoza, who's a clinical research analyst, and Elle Pinkerton, who's a clinical research project manager. And I believe Elle is going to speak first. So Elle, I will throw it to you. Welcome, and thank you so much for being here today.
Thank you. Let me just get my screen up. Uh, Lovely to be back. I had the chance to present here a few years ago on the same project, so it's really nice to be able to give an update.
Yeah.
So today, and I'm just want to say I'm presenting on behalf of my colleague Delaney Rowanchik, who wrote this presentation, but she is in a med school interview right now, so we wish her luck.
Good for her.
And today I'll be talking about basically how we worked with people affected by breast cancer to design our clinical trial to test this device that we're building, which we hope will restore breast sensation after mastectomy. I personally have no conflicts of interest to disclose, and this particular research was funded by both the University of Chicago Women's Board and the National Cancer Institute. So to start, I want to talk a little bit about where sort of the idea for this project came from. Our principal investigator is Dr. Stacy Lindau, who has a clinic at U Chicago where she sees people with sexual dysfunction issues related to cancer or anything else in their lives. And she specifically had a patient who presented to her clinic who was experiencing numbness in her breasts after her mastectomy. And for her, this was really affecting her sexual well-being, her ability to enjoy sex. And so she really challenged us to find a solution to this, because there wasn't really one available for her at the time that she was aware of. And in particular, she said that her breasts looked great after her mastectomy. She was very happy with how they looked, but they didn't feel like hers. And shortly after this patient presented to us, there was actually an article published in the New York Times in 2017 about this same issue. So we, did a little more research into this, prompted by this patient. And we found that, obviously there's an enormous number of women every year who have mastectomies. It's over 100,000 in the US alone. And we saw that up to 60% of those people experienced persistent numbness in their breasts after mastectomy. There are some recent studies that suggest this number might be even higher than 60%. And we also found that between roughly a quarter to 60% of people who have mastectomy also have chronic pain associated with sort of those nerves that are cut as part of the general removing all of the breast tissue process. There are, some existing sort of surgical interventions that are intended to help restore breast sensation or reduce at least the amount of sensation that's lost. That can include nerve preservation, which is typically just trying to it's what it sounds like, trying to keep as many of those nerves intact during the mastectomy as you can. There's nerve grafting where a section of the nerve can be connected to another section to kind of try to connect that bridge that was cut where that nerve was severed. And there's also neurotization, which is uh, typically a piece of nerve, a donor nerve is taken from elsewhere in the body and attached in the target location to in the hope that it will basically start growing off of the existing nerves and produce sensation again in that area. All of these techniques, show some promise, but they have limitations. They're often only available to some people who are getting a mastectomy, depending on, this kind of surgery they're having, their cancer profile, their anatomy. Um, there haven't really, the long-term data, we don't really have long-term data on long-term sensory restoration from these procedures. But in the data we have suggests that, kind of mixed outcomes in terms of how effectively they restore sensation. And also, patients weren't really involved in the development of these surgical approaches until after they were in implementation. So we sort of developed this idea, and this draws on like really foundational work that's being done at Case Western Reserve University in Ohio, where they're using this same neuroprosthetic approach to restore sensation in people who've to like hand prosthetics for people who've had a limb amputation. So this is the device we're proposing. It basically has three main components. There's an electrode that wraps around the wire, almost like it closes like a book around the nerve. Uh, and that transmits electricity to the nerve, and those electrical signals are then transmitted up to the brain and read like as if you're feeling sensation. Our full device that we're imagining also has a neurostimulator that converts pressure signals to that electrical signal to the nerve, and a flexible sensor that would be implanted under the nipple or at the apex of the breast if someone has not had a nipple-sparing mastectomy, that picks up on pressure and sends those signals ultimately to the electrode. So we're still in very early stages of developing this device. So right now we are focusing on this electrode component and just demonstrating that works in the breast similarly to how it works in the like limb amputee population. So yeah, that is our focus for this. And we've been very engaged. We've had a lot of patient engagement. I mean, since the very beginning, this whole idea came from a woman who'd been affected by breast cancer. So pretty shortly after we had the idea for this project, a number of women who had undergone mastectomy, a lot of whom had presented at Dr. Lindau's clinic, were invited to join our patient advisory board. And they've really convened pretty regularly since 2017 through the present, and they've weighed in on the development of our research at every stage. This is just some of our advisory board members here. So as part of our preparation for doing this first trial where we're testing this electrode, on the guidance of our advisory board, they were like, it's good to talk to us, but they also recommended that we talk to more people who've been affected by mastectomy. And specifically, we wanted to talk to women who were currently eligible for mastectomy. So they had either a breast cancer diagnosis or elevated risk of breast cancer, but they hadn't undergone their mastectomy yet. To help give us some insight into sort of the experiences of people in that like really unique point in their cancer treatment journey and what they're dealing with. So we conducted interviews with 13 women who were eligible for mastectomy. And we specifically asked them about, whether they would be interested in participating in a clinical trial related to this research. We went through the risks and benefits of the clinical trial and asked, how acceptable those were, what was concerning to them. And we also just got their general like opinions and preferences about this big implantable device that we were imagining to restore breast sensation. So after we conducted these interviews with these 13 women, we got unspeakably valuable information from them, which completely shaped how we designed our trial. So the women we talked to were very interested in a couple of main outcomes. They wanted to know whether this electrical stimulation would actually restore sensation of the breast. And they also really wanted to know if the electrical stimulation could help with this chronic mastectomy-induced pain, which is an idea we've been exploring more recently. They also told us that they wanted to know more information than we were originally giving them before they could really judge whether they'd be interested in joining this trial. They really wanted to know more about like the history of the project, all of this preliminary work that's been done in people with limb amputations. They wanted to know more about the device itself, like what it looked like, how big it was, how it would feel. Um, they wanted to know like who they would be interacting with during the study, what research staff would be there, and know more information about those people. Um, and yeah, like I said, they wanted to know more about previous trials using this device. And specifically when people heard that, oh, these devices had been used previously in people with arm amputations, and they've been in place in these people with arm amputations for, years at a time, they were like, this is really important to include in your informed consent process. Like, this makes a big difference in considering, whether we think this study would be like safe or like productive to enroll in. And we also learned more about like what aspects of the trial they were more concerned about. So going through the risks, they really wanted to know that the device was safe. They really wanted to know about any extra operating time that would be involved, which I'll get to what that means in a second. But extra operating time that would be involved in putting the device in place and removing it later. And we also, because we were using just electricity, we have to include a notice that there's a possibility of burns or electrical hazards. And that one was also very surprising, and I think relatively concerning to our participants. And that really just showed us the importance of emphasizing like which risks are just related to the fact that they're going to be undergoing, a mastectomy at this time as a major surgery, and which risks are specific to this device being involved. So we ultimately were able to secure funding, and we are currently, our first clinical trial is currently underway, phase 0, so we're very, very early. And basically what we're trying to accomplish with this clinical trial is to demonstrate that by electrically stimulating these nerves next to the breast, that we are able to produce what feels like a sensation experienced on the surface of the breast. We also wanted to know more about like the quality of the sensations that people feel with that simulation. What are they like? And we also want to look into, any potential, does this have any impact on pain? Um, there have been some other studies in other areas demonstrating that like stimulating the nerves can help with chronic neuropathic pain. So that's definitely something we're interested in. Uh, our study was funded by the National Cancer Institute, and they specifically shouted out in our strengths when they reviewed our proposal that we were the first team to design an intervention to preserve and restore breast sensation after mastectomy with co-development from patients. That's always been a huge part of our project, and completely agree that it is one of our biggest strengths. So we ultimately designed our protocol based on that patient input to be as patient-centered as possible. This is just a very simplified timeline that shows study activities for people who are enrolled in the trial. And I think just one relevant detail here is that we are placing this device temporarily. So for people who are enrolled in the trial, the device is placed at the time of their mastectomy. And then later, when they have the second stage of their reconstruction, the tissue expander is removed and either an implant is placed or the breast is reconstructed from tissue. Then we remove the device. So one of the key elements is that no additional surgical procedures involved, like no additional time under general anesthesia. We're leveraging planned surgeries and planned visits. So, we have a baseline study visit that we have to do before someone has their mastectomy, so we can be like, okay, what was your breast sensation like before all of this happened? And we schedule that to align with their pre-surgical anesthesia screen, just to like minimize the number of times people have to come back to the hospital, because we know they've been back at the hospital probably more than they would like to be. We also have a flexible testing schedule. So while the device is in place, we do need people to come in twice a week for testing sessions. But we've been able to schedule, we have one participant who is in the trial now, and we were able to schedule those very flexibly, really just like whenever she was free during the day, whatever days of the week, if she needed to take a week off for a vacation or move a day because she had another obligation, like we keep those visits as flexible as possible. Again, just to like minimize the burden on people who are already dealing with a lot of doctor visits. And for follow-up, so after the device is removed, we continue following up with people just to ask more questions about their sensation, about their pain. But those follow-up visits are just remotely done on the phone. Again, to just minimize the amount of time people have to come into the hospital in person and minimize how much of a burden it is to participate in this trial for someone. We also got a lot of input from the patients we talked to on our recruitment materials for the study, which I think is sometimes like an underappreciated element in terms of how important it is. So we had put together some drafts. We had input from our patient advisors, from the patients in the interviews, from the health literacy team at University of Chicago. And we really wanted to make sure we didn't have jargon, that we kept like the language as simple and straightforward as possible. And the patient advisors, again, really weighed in on like every single part of this, like the words we used, the image, the color of the pants that the woman is wearing. We really got a lot of input on that. And ultimately, this flyer was approved for use in the study by the IRB, which was great. So you can see like throughout our recruitment materials, you can really see like the influence of just how much we learned from all of these women affected by breast cancer that we talked to. Um, one thing that they told us is that they wanted to know more about the study team, like who are the investigators, what are their qualifications, what is their expertise. So we added little headshots for like the co-investigators, and a little description of their role. They also wanted to know more about like the history of the study, why is it important? Like, why does this matter? And so we added more information on just like the prevalence of sensation loss after mastectomy to help people understand why we think this study is important and worth doing. Uh, Another thing that was really completely shaped by patient feedback was our informed consent process. One thing we heard from the people we interviewed is that, when they are sort of in between the mastectomy and reconstruction, again, lot of doctor visits. Often they've received the news of a breast cancer diagnosis relatively recently, and they're really just in information overload. Like you're having so many meetings with so many clinicians that it's almost impossible to remember what you hear at every meeting. So in response to that, we really split our consent meeting up into three different meetings. So at each meeting, people meet different members of the research team and have a chance to ask questions or get detailed information about different parts of the study. And our hope is that by spreading this out over several meetings, people have more time to process that information, think of questions, and maybe bring those back to the next session. And then at their third meeting, that one we have in person, and that's when people finally consent to enroll the study if they're interested. Uh, so we also included in our material. So during this informed consent process, people get like much more detailed information than we have in our like flyer or our brochure. Um, so some of the advice we got from, again, our patient advisors and the people we interviewed is to make it really, really clear exactly what the study activities are and exactly what time commitment is involved. So you can see here, we laid that out in much more detail. Like here are exactly the surveys you're completing during this period. This is when there won't be any research activities because you're just recovering from surgery. So this was received pretty well. People were happy with the amount of information that was on here and thought that it was pretty clear. And also, yeah, people did want to know how much extra operating time was involved, so we've also included that wherever it might be involved. Again, in extra time on top of the mastectomy to place the device, and then on top of the reconstruction to remove the device. People also really wanted to know more about the device, which is fair. We just keep calling it the device. It really adds an air of mystery. you want to know more. So they really wanted to know more about like what the device looked like. And also, as part of our study, the device includes both these electrodes and these thin wires that connect to it. And the electrodes actually exit the skin under the arm, so that we can access those wires to stimulate them. So people really wanted to know more about like the wires and what those looked like. In the informed consent materials, we included images of what these electrodes look like. You can see that what the leads look like when they're implanted, a size comparison of the electrode next to a pencil for scale. And we also had a packaged version of the device so that people could physically look at it with their eyes before they decided to enroll in the study. Uh, and we also updated sort of our explanation of these risks to include information about like how likely it was that, a particular issue might occur based on patients from the other studies who had had these devices implanted. So our patients not only, were instrumental in helping us design the actual study itself and the recruitment materials. They've also been really important in helping us get the word out about our research. So one of the things we developed based on this input we got from all these interviews we did is a educational video about breast sensation loss, and Tanya will be speaking more about that right after me. So patients really told us that this was needed. Patients were involved, starred in the video, told us what we needed to talk about in the video, made appearances, spoke about their own experiences. And also on the right, one of our patient advisors was actually interviewed in and featured in an article in the Chicago Tribune about our research. So they're really helping us get out the word to like not only like, oh, this is what we found, like these are our exciting discoveries, but also, getting that information from people who are directly and personally affected by this, I think really highlights why the research matters, not just what it is accomplishing. So overall, our patient engagement in this study, I think, really falls into like three big categories. Like for one, inspired the idea for the study, inspired the whole idea behind this entire project, and then engaged throughout the development of the trial protocol to really help us end up with a study that has as little burden on patients as we can manage, that studies outcomes that were meaningful to the patients that we're talking to, and that really centers like what they need from a study and the experiences that they've had throughout their mastectomy and their cancer treatment process. Also, again, as I mentioned, really instrumental in helping us develop recruitment materials and informed consent materials so that those would resonate with patients, and to make sure that patients had access to all of the information that they needed to make a really informed decision about whether to participate in this trial. And then lastly, patients have and continue to help us in getting the word of our research about our research out, not only to the scientific community, but to like the broader public, to the whole world of people who are affected by breast cancer. Uh, and then ultimately, just to wrap it up a little, our project, we think has a few different aspects that are really innovative. We are shifting the focus of the post-mastectomy sort of outcomes from appearance to function, which is like in line with, I think, a broader movement through in the breast cancer world. We have this bionic approach, which, this is the first time that this has been adapted from the limb amputee population to another population, which is very exciting. We also developed this entirely in partnership with our patients. They are as much responsible for this idea and for this trial as we are. And so we really hope that this protocol, is not only interesting to learn about like new breast cancer research that's happening, but we're also hoping that it can be like a good example of and like that it can emphasize the reasons why it's so important to engage patients in research, not just at the end, but from the very beginning, as early as possible, as often as possible, wherever you can get input from the people who are actually affected personally by the issue that you're studying. It adds an enormous amount of strength to the study. And we do have an Instagram account. You can follow us there. You can also see clips from the educational video that I talked about and learn more about the study. And I have Delaney's email here. Again, she's the author of this presentation. If you have any other questions or would just like to talk to us about the study, please feel free to reach out. And we do want to acknowledge just our co-authors on this particular research, and also, of course, our patient advisors and our interview participants, which, as should be clear by this point, we couldn't do any of this without them. And I will hand off to Tanya to talk more about our educational video.
Yeah, thanks, Elle, for that wonderful tee up to everything. So I'm going to share my screen. Just give me 1 second. Um, okay, so I will be talking a little bit more about the patient education video that we made and the pre and post viewing study that we conducted at a couple different conferences internationally. And how those audiences viewed our video. Um, so, like Elle, I also have no conflicts of interest to disclose, and our funding is also from the University of Chicago Women's Board, as well as the U Chicago Bucksbaum Siegler Institutes of Clinical Excellence and the National Cancer Institute. So Elle touched on this in her presentation as well. Up to 60% of women who undergo mastectomy procedures experience some level of breast sensation loss. And overall, it's a very well documented outcome after breast surgery. In the scientific literature, we've seen that breast sensation loss is really important to patients, and that loss of breast sensation after mastectomy can negatively impact patient satisfaction and quality of life. So, in these two figures, you can see in this recently published study with 174 patients who either underwent nipple sparing mastectomy or breast conserving surgery. Um, Nearly 80% of all respondents, so in this red square in both of these figures, had some level of importance. They felt that breast sensation had some level of importance to them. Um, this also lines up with our own qualitative research. So Elle mentioned those qualitative studies that we conducted. Here's a quote from one of our patients where she says, "I can't feel most of my front, and it impacts me in so many ways, from getting wet when washing up, not noticing shirts being open, to sex." And patients in other qualitative studies have also reported that their breast sensation loss was unexpected. So, one patient in a study stated, "I wasn't expecting that when I would touch my skin, I wouldn't feel anything at all." There is one thing that can make a difference in these outcomes, and that's education about breast sensation loss. So, in a mixed method study with 22 women after mastectomy, researchers found that women who reported a clear understanding and preparedness for a loss of breast sensation after mastectomy tended to report higher satisfaction with their breasts. However, effective patient-clinician communication about this outcome is challenging. There's a lot to discuss when people are thinking about their surgical treatment, and so discussion of sensation loss can sometimes be a lower priority. And this gap in communication is exacerbated by a lack of high quality, publicly available education content. So, studies have looked at online videos on breast cancer surgery, and they found that there really is a lack of quality educational content for patients on these platforms. Um, these studies found that mean health information quality scores, which look at how good a product is at disseminating health information, these scores were poor to moderate at best. And they also noted that videos had a lack of content focusing on quality of life and personal outcomes, including body image and breast sensation. So these studies really called for more clinicians to create high quality educational content. Um, Here you'll see a figure that describes the self-efficacy theory of motivation by Dr. Albert Bandura. So this framework has been used to understand knowledge sharing and communication between patients and physicians. So according to this theory, motivation for behaviors in individuals can be achieved through one's belief that they can successfully accomplish a task. This is known as self-efficacy. You can also refer to it as confidence in being able to perform a task. Greater self-efficacy or confidence in sharing knowledge and communication is thought to influence clinicians' motivations to engage in this behavior. So, knowing where to find reputable resources can increase confidence in sharing knowledge and thereby increase the likelihood of communication about breast sensation loss. There are four main factors in Bandura's theory that are thought to influence self-efficacy. So the first is performance experience, which is like firsthand experience of accomplishing a behavior. Vicarious experience, which is observing others succeed at accomplishing a behavior. Social persuasion, which involves receiving encouragement and positive feedback from others. And then your physiological state, which refers to your physical sensations and emotions that you feel when you're performing a behavior. So, targeting these factors to improve self-efficacy can then increase likelihood in behaviors like sharing knowledge and increasing communication during patient and clinician interactions. So, with this in mind, and also knowing that there was a gap in public video education, we created the Focus on Educating Everyone on Sensation Loss video. This video was developed by clinicians, including a breast and reconstructive surgeon, as well as clinicians that had expertise in oncosexuality. And we also created this video with input from our patient advisory board. Our main goals with this video were to provide knowledge of what to expect in terms of sensation loss and pain after mastectomy, using clear, direct, medically appropriate language so that patients and surgeons could have more confidence and knowledge to discuss this breast sensation loss with each other. So I'm going to stop sharing my screen for a second so that I can share this video. Give me 1 second. Okay, and you can just let me know if you're not able to hear the video.
You know, if you sit on your leg for too long and it falls asleep, and then finally when you're trying to get sensation, it just feels like it aches a little bit, but yet you can't really feel anything, so that's how it feels. Around the nipple itself, absolutely nothing. Like, I think one day I pinched as hard as I could and felt absolutely nothing. So it's like, okay, there's nothing here.
So I wear a prosthesis. And I'll forget to put my boob in. And I'm at the gym. And I'm like, oh man, one side's lopsided. I don't have sensation, I would say, from right here to about a little under my armpit.
I always feel like I have a tight jog bra on. It doesn't hurt, it's not uncomfortable, it's just there. You know it.
Driving, putting the seatbelt on, sometimes I can't find a comfortable spot. You don't feel anything.
Breasts move, they bounce, they float in a swimming pool, and they help a person know where they are in space. In addition, of course, for many women and their partners, the breasts play a very important role in sexual function. In the United States alone, 100,000 women a year have one or more breasts removed. What women know about sensation or what to expect for sensation after mastectomy really varies. Sometimes women don't even know to ask questions about that, and they don't realize that they're going to have a loss of sensation. And it relies a lot on the quality of conversation and communication with the surgeon.
One of the things that my patients find surprising when we're talking about a mastectomy procedure is really the scope of that surgery. The breast itself goes all the way up to the collarbone and down to where the breast fold is, and then of course to the midline and out to the side. We operate in that entire area. All of those nerves that travel through the breast that go to the skin are cut. What this can do is it can interrupt the ability of that skin and nipple areolar complex to feel touch, to feel temperature, and result in the patient experiencing numbness that's generally permanent. Some patients notice a little bit of improvement, but largely patients, once they have numbness after surgery, it doesn't resolve, it doesn't get better. So in that instance, it really is more about the patient getting used to it, their body adapting to a new normal, rather than regaining sensation after surgery.
That nerve that was going to the nipple and was going to the skin has been removed, but there's still a cut piece of it along the chest wall. So now you have basically no capacity to feel or to have sensation, but still all of that capacity or that perception of pain at that cut nerve end. So when we talk about patients may have numbness or they may have a loss of sensation after surgery, a lot of times they equate that with, oh, then I won't have pain, or I may not have pain, and that's unfortunately not true. I think one thing that has struck me as I started talking more about sensation with patients is how important it really is, and they don't always bring it up. So my advice to the surgeons out there that might be watching this video is to discuss it. This is something we know is going to happen. You have to cut those nerves. We know they're going to have a change in sensation, and I think that that's not necessarily a complication, but it is a byproduct of the operation, and they should know that.
Nipple erection is an important part of the sensation and pleasure that a woman can feel during sexual activity. And the responsiveness of the nipple to a partner stimulation is an important part of their sexual response and physiology. So loss of nipple erection for some people can feel as significant as loss of erection or sensitivity or responsiveness of the clitoris. Or men can relate to imagine what would it be like to lose the erection ability of the penis.
It was the point of the nipple erection that I was more worried about, that if I don't have that, will I be able to orgasm? Will I be able to be more intimate? Will I find that connection?
You never think about what does your breast mean for you during sex. It just happens, but when you're going to lose your breasts and you do, then you're like, wow, yeah, that really was important to me.
The loss of breast sensation can be very distressing and will vary from person to person. We all have a need to feel touch, which can be a source of pleasure, as with intimacy, but also a source of comfort, as with a hug.
It's just different now. So now even my son knows if we're cuddling and watching a movie, he'll put his head on my right side versus my left side.
A lot of times we may skip over something or not bring it up because we're kind of going through the process and thinking about 10 different things at once. And it's not because I've missed something or because I'm trying to hide something. It's because, that's not the direction that the conversation may have gone. And so I think it's always helpful to me when patients come in with a list of questions, but they always will apologize for it. And I always tell them I would much rather I know what's on your mind and what's important. And even if that takes a little extra time, at least I know we're hitting those points.
I think we often, as providers, shy away from the kind of the most extreme details of it because we're worried about, scaring our patients unnecessarily or giving them too much detail. But I think, in fact, our patients are asking for more detail about what their body's really going to go through so that they can prepare for the after effects of that.
I think the biggest advice I can give patients is that they need to listen to all options. Because a lot of times when you hear cancer, it clouds everything else, right? And the only thing you can think about is getting rid of it and not dying, right? But then, you don't think about life after that point.
Ask maybe one question, start there.
I would say what really helped me get through it was my surgeon just provided space and really was open to hearing my concerns And she didn't see me as a number.
I think everyone's situation is different. It's what you're facing and it's, what you can handle. If you have support, then you can get through anything.
Okay, so give me 1 second. Okay, so that was the video that we created with patient input. Um, and we presented that video at the Scientific Network on Female Sexual Health and Cancer last year for the first time. And at this conference, as well as others, we collected pre and post viewing data from these groups. And for this short study, we hypothesized that watching this video could promote clinicians and professional self-efficacy or confidence in their ability to find resources on breast sensation loss, as well as the likelihood of sharing this video with others. So ultimately, we had 82 participants from 3 different conferences: the Scientific Network Conference in Ohio, the Plastic Surgery Research Council in St. Louis, Missouri, and the Australian Society of Plastic Surgeries Conference in Sydney, Australia. And we distributed a pre and post viewing survey to participants. In this pre-viewing survey, we asked people to indicate their roles, and they could choose several roles if that applied to them. And then we also asked them to rate their confidence on 2 statements using a 5-point Likert scale from not at all confident to very confident. And these were adapted from the Bandura's self-efficacy theory that I shared a little bit ago. And we also included an open-ended question to elicit responses on what resources participants currently use to talk about this subject, either to educate themselves or to talk about it with patients. And then in our post-viewing survey, we asked those same self-efficacy questions and also asked participants to share their likelihood in sharing the video with their professional network. And this was based off the Net Promoter Score questionnaire, which is pretty widely used in customer experience measures. You might be familiar with it. So it's limited in its ability to accurately assess satisfaction on its own, but there is evidence that high Net Promoter Score ratings are associated with higher satisfaction. Since we were collecting data in like less than 10 minutes, we chose to use this one item measure to just get an idea of satisfaction. On this scale, a score of 0 to 6 indicates that a person is a detractor, meaning that they're very unlikely to share something. A score to 7 to 8 is a passive person, meaning they're satisfied, but they may not share it. And then a score of 9 to 10 is that they're a promoter and very likely to share it. We also asked people to have to give any feedback on where we think we should share this video, as well as any thoughts that they might have about the video itself. So for our statistical approach, we ran descriptive statistics to describe participants' likelihood of sharing resources, and we used McNemar's test for paired nominal data to evaluate the video's impact on confidence. In terms of outcomes, we categorized participant scores into either high or low confidence, and then looked at these changes in confidence. So here I summarize the roles of the survey participants from our 3 professional conferences. Among these 82 participants, a majority identified as clinicians or practitioners, and about 1/3 also identified as researchers. And again, people could choose more than one role, and about 20% of people chose 2 roles or more. So the percentage of participants who indicated low confidence in knowing where to find resources was about 78% prior to viewing the video. And the percentage of participants who indicated high confidence was about 22%. And then after viewing the video, the percentage of participants who indicated low confidence went down to 35%, whereas the percentage of participants who indicated high confidence increased to 65%. And in this table, or in this graphic, you can see how this changed. So McNemar's test was used to determine whether the proportion of participants who reported high confidence changed significantly. Um, Prior to viewing, 18 people had high confidence, and of these 18, 17 stayed highly confident, and one person moved down from high to low confidence. Prior to viewing the video, 29 of the low confidence participants remained low, and 35 went to high confidence. So overall, 52 participants reported high confidence and 30 reported low confidence, and this was shown to be statistically significant. Looking at that 0 to 10 rating score, 74% of people were promoters, either giving a score of 9 or 10, and 19% were passive or giving a score of 7 to 8, and 7% gave a score of 6 or below. The mean score was 9 out of 10, and the median score was 10 out of 10. And then about 2/3 of participants endorsed some sort of channel for dissemination. So this included 15 unique scientific conferences, including ASCO, and as well as patient groups like the Young Survival Coalition or the Breasties. And we also had people encourage us to post it on social media and translate the video into different languages. So going back to Albert Bandura's self-efficacy theory of motivation, our video primarily targets the vicarious experience and social persuasion factors. Clinicians and patients are sharing their experience and knowledge on breast sensation loss and also sharing what worked for them in terms of communication. And they also are encouraging other clinicians and patients to talk about it with each other, or social persuasion. So by watching the field video, clinicians' self-efficacy and finding resources can increase, which would also increase the likelihood in sharing knowledge and opening this discussion during patient-clinician interactions. Our high mean and median scores and high percentage of promoters indicates that there's a high likelihood that people would share this video, as well as a high likelihood that people were satisfied with the video. There are a few limitations. These data were collected at conferences with professionals who have expertise in oncosexuality and people who are interested in breast sensation loss after mastectomy. So these results can't be generalized to the general population of clinicians and broader audiences. And then these data also don't include patient perspectives, which is really important for us to gather, and we are collecting this data via online patient groups. And lastly, the Net Promoter Scale means that we can't make definitive statements on clinician satisfaction, but those high scores do show that it is promising. So there's a couple key takeaways for this study. There's a lack of evidence-based publicly available educational content, and our findings show that this video is acceptable to experts, which means it can serve as an effective tool for patient education. Educating patients is really important about surgical procedures, and so having this video would improve informed consent for mastectomy and other breast reconstructive procedures. So really quickly, I want to acknowledge my co-authors, as well as our video production help and our patient advisors and video participants. And again, if you're interested in our Instagram, where we post these videos and our research findings, you can scan this QR code or just put in Bionic Breast in Instagram. Yeah. Thank you. Any questions, thoughts?
This was awesome. Thank you both so much, Tanya and Elle, for presenting today on this topic. I had a couple questions come into me, and man, we are just about at time, so I'll have a couple questions, and then we will wrap up. So the first question is asking, what are the next steps for the Bionic Breast Project? As I mentioned, you're still really in the preliminary phases in terms of clinical research. So what are the next steps?
Yeah, that's a great question. I would say our next steps are, well, sort of in parallel with working on the electrode, we also have a collaborator who is developing the like soft implantable pressure sensor. which that is very cool, like material science, like biocompatible polymer work that is way beyond my comprehension. Um, and we are also exploring currently, I think our one of the next things you want to do is find a way to, instead of having that stimulation take place, at the lab provided by researchers, to have people be able to have a take-home version of the device where stimulate sort of a closed loop stimulation, where the stimulation is in response to either, you're able to hit that stimulation button yourself to feel sensation, or there's some other kind of non-external sensor that's picking up that signal. So I think that is our next step, is finding a way to sort of get it out of the lab into like everyday life.
I was muted, sorry. Would this be something that would be commercially available down the line? Is that sort of the goal here?
That is the goal, yeah. And we've been learning a lot about how long device development takes. I think our current estimate is that the full device we're imagining with the implantable pressure sensor and everything, probably like maybe 10 years from now, we would be doing clinical trials of it, and then maybe another 5, 10 years after that, it might be commercially available. But we are hoping to make other versions of it available sooner. And yeah, the long-term goal is to have it both commercially available and covered by insurance
Mhm.
one way or another.
Wow. Oh wait, that's I mean, I knew it took a long time. That's longer than even I thought. That's crazy. Wow. And then a question came in here. Would this be so this is currently used for women undergoing mastectomy. Do you see a use for this with people within the trans community who are transitioning from male to female? Could there be a possible use of this for that as well?
Yes, absolutely. And that's something I'm really excited about. We know from like again the research on in the trans community, as we know, is lacking for a lot of reasons. Uh, and but we know somewhat from like community sourced data from the trans community that people who have top surgery typically have better sensory recovery outcomes than people who have mastectomy with reconstruction. A variety of reasons for that, including that they don't have to be quite as careful about removing all of the tissue because they're not worried that some of it might have cancer in it. But I definitely see applications for this in the trans community. We've been talking to some people who are interested in its applications for people with like vulvar cancer who've lost clitoral sensation. So we very much see this as something that could apply to a lot of different parts of the body that have lost sensation for one reason or another.
That is so interesting. Okay, I'm gonna cap our questions there. Thank you so much again to Elle and Tanya for joining us today. This is just a really cool and unique research project, and we're so grateful for all the work that you all are doing on this to help women of all kinds experiencing these issues. So thank you both so much for being here today.
Thank you for having us.
Okay.